My dear students, in this video, I am going to discuss some important points regarding heparin-induced thrombocytopenia, what we call Hitt, and a case-based presentation. So let us start with this case scenario. A 62-year-old man was admitted with NSTEMI and he underwent PCI. He was started on unfractionated heparin infusion. And on day 6 of hospitalization, the platelets fall from 2.4 lakhs to 95,000 with new painful swelling of the right leg, and the Doppler reveals acute femoral DVT. So there is a fall in the there is thrombocytopenia. But what is important here is to understand that is this bleeding from heparin, or is there something which is more dangerous that is hidden behind it? So when we think about heparin-induced thrombocytopenia, we have to know the mechanism by which heparin causes this bleeding. Heparin binds to platelet factor 4, and there is formation of platelet factor 4 and heparin complexes. And as you can see that IgG antibodies are formed against this complex. And to this immune complex, the Fc portion of the IgG binds the platelets Fc gamma 2 effectors, and this causes platelet activation, giving rise to platelet release, aggregation, and release of procoagulant microparticles, eventually which leads to thrombin burst and produces thrombosis. And this platelet removal by the macrophages and the spleen produces, and the reticular endothelial system produces thrombocytopenia. So, Hitt is a prothrombotic immune mediated adverse drug reaction caused by antibodies against PF4 heparin complexes, which leads to platelet activation. And to diagnose that, we have to look into the key clinical clues that are available in the patient. That is, the platelet falls more than 50% from the baseline, which happened in this patient. It occurs usually 5 to 10 days after the heparin exposure. Presence of new thrombosis, as it is evident in the Doppler ultrasound, and no alternative cause of thrombocytopenia can be explained in this patient. And in such patients, we have to do an estimating the pretest probability using a 4T score, where the 4Ts are thrombocytopenia, timing of platelet decrease, thrombosis, and other causes of thrombocytopenia. So a total possible of 8 points can be attached to this 4T score. As you can see, 2 points for 1 point and 0 point, 2 points for a thrombocytopenia of more than 50% fall, or a nadir of more than 20 to 10 to the power 9 per liter, where a timing of clear onset between days 5 to 10, or platelet fall of less than 1 day if the prior heparin exposure within 30 days, thrombosis, that is new thrombosis or skin necrosis, acute systemic reaction, post IV heparin bolus, and other causes of thrombocytopenia, none is evident. So all of this carries a score of 2 points each. Now, if the fall in thrombocytopenia or the fall in platelets is 30 to 50%, or a nadir is between 10 to 19 into 10 to the power 9 per liter, or if the timing is consistent with days of 5 to 10 fall but not clear, and onset is after 10 or day 10, or a fall is less than equal to 1 day if prior heparin exposure of 30 to 130 days, or if the thrombosis is progressive or current thrombosis, non-necrotizing skin lesion, suspected thrombosis not yet proven, and other causes of thrombocytopenia are possible, then each of this factor has 1 point. And similarly, if the fall in the platelet count is less than 30%, or the nadir is less than 10 into 10 to the power 9 per liter, with the timing being of platelet count recall of less than 4 days without recent exposure, no thrombosis, and no definite causes, and there are definite causes of thrombocytopenia, then the point is 0. So if the score is between 0 to 3, the probability is less than 5%. If it is between 4 or 5 and it is intermediate, and if it is 6 to 8, then the causes is very high, that is more than 50%. So if the low 40, then a hit ruled out clinically. If it is intermediate or high, then we have to stop heparin immediately. Now, when we look into the types of Hitt, we come across two distinct types broadly, the type 1 and type 2. The type 1 is non-immune, whereas Hitt type 2 is immune, mediated by IgG. The onset is early, between 1 to 2 days in type 1, 5 to 10 days in type 2. Platelet fall is mild in type 1 and it is more than 50% in type 2. Thrombosis is not there in type 1 and there is thrombosis in Hitt type 2, and action is to observe the Hitt type 1, and in type 2 we have to stop heparin immediately. So only type 2 and its variants are clinically dangerous. Type 1 is benign and usually self-limited. There are one or two other variants too which one should remember, and this can come as short note for the DMF, the DRNB candidates. One of them is the autoimmune Hitt. Autoimmune Hitt is rarely the clinical manifestations of Hitt can develop via heparin independent platelet activation. So this is autoimmune Hitt. It refers to any Hitt related platelet count fall that begins or persists in the absence of heparin. There are 6 subtypes of autoimmune Hitt, and notably spontaneous Hitt has been reported to occur after knee replacement, although there is another term for it. I am coming to that. So just remember that there can be 6 subtypes, and the features are profound thrombocytopenia, that is less than 20,000, refractory thrombosis, and positive functional assays without heparin. So this is important, and the management consists of non-heparin anticoagulants, but IVIG may be required. Another spontaneous Hitt-like syndrome or Hitt mimic, and that is possible without prior heparin exposure, which is seen in orthopedic surgery, severe infections, and rarely following post-vaccination, although some people consider it as a separate category, others consider it as a part of spontaneous Hitt-like syndrome. And the mechanism is anti-PF4 antibodies, which are independent of heparin, so which causes this platelet activation. So if you go by the history and if you try to collate the findings, the innovations, the original Hitt, which was the classic Hitt that was first postulated in 1973, which was triggered by heparin and in certain polyanions, and it was heparin dependent antibodies were. So there is heparin or polyanion triggered. So this heparin dependent antigen sites, these are North Pole and South Pole. The North Pole is the N-terminal lysine rich region, and there is in between there is a ring of positive charge representing heparin binding site, which is called the equator, and South Pole there are heparin independent antigen sites also. And in 2001, we came to know about the autoimmune Hitt, which was also triggered by heparin, but they had both variants, heparin independent and heparin dependent antibodies. In 2008, we heard it came about the spontaneous Hitt, which were the triggers were total knee arthroplasty or infection. They were primarily heparin independent antibodies. And in 2021, we had this VITT, that is vaccine induced thrombocytopenia thrombosis, which was also triggered by adenovirus vector vaccines, which was heparin independent antibody. So at one end we find heparin triggered, and the other end we find non-heparin triggered causes of thrombocytopenia and thrombosis. So what are the tests one needs to do? One of the other than the ones, these are the immunological tests. PF4 heparin ELISA has high sensitivity, but the specificity is low. And the functional assay is the gold standard, of which the serotonin release assay is the one which is performed and which confirms the platelet activation. There are certain advantages and disadvantages of each of these tests. Like the PFA, advantages are that no plate preparation stage, conditions similar to natural, but the disadvantage is that distortion of the results by various factors like the number of platelets, hematocrit, von Willebrand factor. Then the method requires pipetting. That is, it should be tested in very small amounts. In other than that, there are other tests like Verify Now or optical turbidimetry, but the major disadvantage is that it is highly cost and specific range of platelets can only be tested. The advantages are all but are there, like small volume is needed, simple operation, fast and standardized procedure. And likewise, there are similarly other tests, including up to flow cytometry. But never delay treatment waiting for tests. And whenever you suspect uh, the HIT, heparin-induced thrombocytopenia, and the risk is high as per the 4T score. So while sending, you should start the treatment. So what should be done immediately? You should stop unfractionated heparin or a low molecular heparin, whichever heparin the patient is getting. Also should stop all heparin coated catheters if they're being used on heparin flushes. You start non-heparin anticoagulant, and in different settings, different drugs are preferred. Um, Argatroban in the setting of ICU and liver, in bivalirudin in the setting of PCI or ECMO, fondaparinux in stable patients, and DOACs in stable outpatients. But never start warfarin early because they can cause venous limb gangrene, and should only start once the platelet count reaches above 1.5 lakhs. Regarding the choice of non-heparin anticoagulant, argatroban suits mostly the patients who are in the ICU, which is a IV direct thrombin inhibitor. Hepatic metabolism is there, for which it is ideal in renal failure, has a short half-life of around 45 minutes. The dose is to start at 0.5 to 1 mics per kg per minute, slower in shock and liver disease, and the target APTT should be 1.5 to 3 times the baseline values. The other is bivalirudin, which suits, although not available in India, both of them. Bivalirudin suits only the cardiac surgery, ECMO, or the PCI patients. This is also an IV direct thrombin inhibitor with predictable kinetics, partial renal clearance. So this may not be a good choice in renal failure, but is more suitable in hepatic failure. The dose is 0.05 to 2 milligrams per kg per hour in ECMO. In the ICU, monitor APTT or ACT, favored when ECMO circuit is clotting, in post CPB hit, and when there is need for procedural anticoagulation. Fondaparinux can be used in stable non-ICU patients. It is an indirect factor X inhibitor, once daily subcutaneous dosing, off level, but there is strong evidence of its benefits, but it should be avoided if the creatinine clearance is less than 30 ml per minute and in unstable ICU patients. The DOACs, or the direct oral anticoagulants, they're emerging option, both rivaroxaban and apixaban. They can be administered. No monitoring is required, and increasingly they are getting supports of the society guidelines. But used only when the platelets are recovering, patient is stable, there are no imminent procedures. There are some recommendations for direct oral anticoagulant use with regard to the dose in patients with Hitt or Hitt thrombosis. If it is Hitt with thrombosis, the apixaban dose is 10 mg twice daily for 7 days, then 5 mg twice daily for 3 months. In patients with isolated Hitt, the dose is lesser, 5 mg twice daily until platelet recovery or up to 6 weeks. Likewise, there are doses for rivaroxaban, dabigatran, but edoxaban is not recommended because of current lack of supporting literature. So Hitt with or without thrombosis, do we require different treatment? Hitt with thrombosis should be treated as acute VTE with full dose anticoagulation, and the duration should go for at least minimum of 3 months. In isolated Hitt where there is no thrombosis yet, they still require a full dose anticoagulation. The thrombosis risk is up to 50% if they're not treated, but the duration is less and the minimum duration is only 4 weeks. But we have to remember that routine platelet transfusion versus thrombosis and fuels platelet activation. So platelet should not be administered unless there is acute severe hemorrhage, ICH, etc., or there is some procedure, because low platelets does not always increases the bleeding risk in Hitt. The thrombosis is even more dangerous. Now, there are warfarin associated problems, because warfarin is dangerous because it produces a rapid drop in protein C and causes unopposed thrombin activity and even causes venous limb gangrene and skin necrosis. So, if warfarin is already started, one should stop immediately, give vitamin K, and continue non-heparin anticoagulation. The rules for heparination start only when the platelets are more than 1.5 lakhs, patient already anticoagulated with non-heparin agent, and there is an overlap for more than 5 days. You have to remember that PA4 antibodies may persist for weeks and they can sustain the thrombotic risk. So the risk of thrombosis is paramount and is much more than the risk of bleeding. How do we monitor response to treatment? We respond by platelet recovery, which usually begins within 2 to 3 days and normalizes in about 7 days, 7 to 10 days. Clinically, there will be no new thrombosis and there will be stabilization of the circuits and catheters. In the acute phase of it, we initiated direct thrombin inhibitor therapy, and in that case, we typically until the platelet count recovery occurs, we have to monitor them. Once they are more than 1.5 lakhs, we usually follow a two-step approach. That is the discontinuing the direct thrombin inhibitor and initiating fondapirinox. And in the step 2, continue fondapirinox, initiate warfarin therapy, overlap period until INR therapeutic for at least 5-day period. So this is the two-step approach using fondapirinox in the step 2 stage. So why is Hitt different in the ICU? Because ICU patients have multiple competing causes of thrombocytopenia. They can have sepsis, they can have DIC, they might be undergoing CRRT, they're receiving a lot of drugs which can cause thrombocytopenia, frequent heparin exposure, and high thrombotic risk. So missing Hitt can be catastrophic, and overcalling it leads to bleeding and circuit failure. So whenever it is present, we have to see the series of events. One needs to look into it. Like in this scenario, there was initial presentation at a peripheral secondary care center where the patient was intubated, started on UFH. There was initiation of dexamethasone treatment, then detection of VAP at start of piperacillin tazobactam, and we suspected he developed at around day 17 during ECMO. And it was so there was switch from heparin to argatroban and renewal of the ECMO system, etc. The positive anti-P4 heparin and everything came to around between day 18 to day 19. And finally, hemoglobin relevant bleeding from the ECMO cannula, etc., occurred on day 19. And there was positive HEPA test, definitive confirmation of it, and further continuation of argatroban from day 25. So this whole journey one needs to carefully monitor, and especially 5 to 10 days after receiving heparin, one needs to be particularly attentive. Now we have to know something about Hitt in cardiac surgery or post CPB ICU, where the expected platelet fall after cardiopulmonary bypass is around 30 to 50%. NADI typically develops on day 2 to 3, and it is recovery occurs by day 4 to 5. Unfractionated heparin exposure is almost universal. So when to suspect Hitt? When the second platelet fall occurs around 5 to 10 days because of the biphasic pattern and the platelets fail to recover after day 4. There are new thrombosis like SVG occlusion, limb ischemia, stroke, etc. The diagnostic pearl is early thrombocytopenia does not lead to Hitt. Late or biphasic thrombocytopenia can be lead to Hitt until proven otherwise. Management again should be to stop all heparin, start bivalvuridine, which is preferred in post-cardiac surgery, and also avoid platelet transfusion unless there is life-threatening bleed. Now, Hitt on ECMO. ECMO can be either venovenous or venoarterial. Venoarterial is more commonly where Hitt has been encountered. ECMO circuits amplify platelet activation, and Hitt causes oxygenated clotting and circuit failure, and there is thrombosis plus bleeding risk. Both will coexist. So the anticoagulation choices is bivalirudin, which is most preferred, and argatroban if renal failure is occurring, because this is metabolized in the liver. Monitoring, the APTT goal should be 1.5 to 2.5 times the baseline. ACT may be, the monitoring may be done, but it is less reliable than APTT, and we should watch for rising transmembrane pressures because that will indicate circuit thrombosis. The practical ICU tip is recurrent ECMO circuit clotting plus falling platelets occurring should lead you to think that it is early Hitt. Now, Hitt can also occur in CRRT or in dialysis patients. Dialysis requires frequently use heparin. Uremia itself causes platelet dysfunction, and high baseline thrombosis risk is also there in these patients. So the anticoagulation options is argatroban because this is the drug of choice in renal failure, regional citrate anti-reducit if expertise is available, and avoid low molecular weight heparin and heparin flushes. So the dose of argatroban is also important, 2 mics per kg per minute, but 0.5 mics per kg per minute in patients with altered liver disease or frank liver failure. Vivaluridine 0.15 milligrams per kg per hour. This is all the same dose in liver failure, but in patients with renal failure or combined liver and renal failure, they will require adjustment. Hitt in pregnancy and obstetric ICU, there are pregnancy-specific causes of thrombocytopenia, which can be isolated thrombocytopenia like gestational, or thrombocytopenia associated with systemic disorders like HELLP syndrome, preeclampsia, the acute fatty liver of pregnancy, etc. There can be also non-pregnancy specific like isolated thrombocytopenia because of primary immune thrombocytopenia, secondary ITP, drug-induced thrombocytopenia, type 2B von Willebrand disease, etc. Thrombocytopenia associated with systemic disorders like hemolytic uremic syndrome or thrombotic purpura, SLE, antiphospholipid syndrome, etc. So low molecular weight heparin can still cause Hitt. Preferred agents are fondaparinux. Of course, the same precautions should be level that the creatinine clearance should be more than 30, and argatroban for short-term ICU use, but we should avoid warfarin, which is teratogenic. What is should know that the quality improvement in diagnosis and treatment is required whenever there is acute Hitt, suspected Hitt or Hitt exposure. The goal for acute Hitt is to decrease the exposure to unfractionated heparin and to decrease the incidence of Hitt. The intervention, the avoid heparin initiative, where replacement of UFH with LMWH for prophylactic and therapeutic indications, and as an impact there has been reduction in the total incidence by almost 79%, and Hitt with thrombosis incidence by 91%, with reduced Hitt related costs in US. Again, with suspected Hitt, it is necessary to decrease unnecessary testing for Hitt, clinical decision support requiring 4TS score calculation with all Hitt assay. And again, with this, the impact has been that there has been reduced proportion of tested patients with low 4TS score from 66 to 56%, and screening and functional assay testing by 37 and 85%. In acute Hitt, the goal should be to increase appropriate use of non-heparin anticoagulants, creation of anticoagulation steroidship program with a focus on anticoagulation in Hitt as an intervention, and the impact has also been a reduction in the median duration of IV direct thrombin inhibitor use, reduced time from diagnosis to discharge, and increased fondaparinux and oral 10A inhibitor prescribing rates. So whenever we see thrombocytopenia on heparin, we have to discontinue heparin, send assay. If there is high clinical suspicion, evidence of thrombosis or prolonged anticoagulation, then one has to begin alternative anticoagulant. If the renal function is okay, one can go for argatroban or lepirudin if it is available. Otherwise, if it is abnormal, it is lepirudin. If the liver function is okay, one can go for both argatroban and lepirudin. If it is abnormal, it can be go for argatroban or Arixtra, although it is not FDA approved. After depending upon the Hitt results, Hitt antibody positive, continue alternate anticoagulation until the platelet count is more than 1.5 lakhs. If the Hitt antibody is negative, but it still may be Hitt, so get serotonin release assay and rule out DIC with fibrinogen and D dimers. If negative, we should continue as above. If the suspicion is low, we can prolonged anticoagulation is not required and substitute with intermittent pressure stockings, because that will also give necessary protection. So my final take-home message would be that thrombocytopenia plus thrombosis should be considered as Hitt until proven otherwise. Bleeding is rare despite low platelets. Platelet transfusions worsen thrombosis. Low molecular weight heparin can also cause Hitt, and prior exposure will produce rapid onset of Hitt. In the ICU, Hitt is less about low platelets, but it is more about uncontrolled thrombin generation. So treat early, treat fully, and never wait for the labs. Thank you.